My name is Muir. I'm in Oxford at the Oxford Centre for Triple Value Healthcare. And our mission there is to help people face up to the challenge that is coming. Need and demand will go up faster than resources. Now, we need to think, what have we tried up to now? And we've done pretty well in the last 20 years. So what we've tried in the last 20 years have been prevention, evidence-based decision-making to make sure we're only funding cost-effective interventions, quality improvement and cost reduction. And those have all been great. But when we look at what's happened in the last 20 years, we see at the end of it, there's still huge unwarranted variation. For example, in England, there's a twofold variation in spend on almost every condition. The big fourfold variation in hip replacement. So unwanted variation. And unwanted variation shows either there's underuse of high-value interventions, like hip replacement, and that's often combined with inequity. Poor people get less healthcare than wealthy people from the public services, not the private sector. The other thing is overuse, and we're seeing increasingly concern about overuse. That's using healthcare to people who probably don't understand the risks associated with healthcare because they assume that everything we do in modern medicine is wonderful. So unwanted variation, overuse, and underuse. Now, value is a difficult word in every language. In the plural, it means principles. Our values are, for example, clinical excellence and compassion in this hospital. But in the singular, it's got much more of a sort of economic meaning. And the same would be used on market stalls or by farmers or by fishermen. And there's four different dimensions of value. Firstly, there's value for the individual. So the question is, what was the problem that was bothering that person most? And what is the outcome? So hip replacement, to use that example, is a cost-effective intervention. But what was really bothering the person most? And did they try other things which had lower risk than hip replacement? Secondly, once the money's been allocated to, say, a land or to a hospital, what is the value that people with asthma are getting from the resources? So I reckon in Austria it's about 130 million euros a year, but there's probably poor people are getting less good treatment. The ones the hospital are seeing are not necessarily the ones who benefit most from the hospital service. And it may be there's overuse of some asthma treatments. Not that I mentioned saving, but maybe that resource should be going to treat people with chronic obstructive pulmonary disease. So all the time we're looking for shifting. So that's personal value, technical value from the use of resources. The third is what we call population value. And I can't see in Austria, and I find it difficult to see in England, has anyone actually decided how much we want to spend on cardiac disease compared to cancer, for example? Or should we switch resources from musculoskeletal disease to respiratory, or vice versa, because it might be different in different lender. And then the fourth type of value is social value. What impact is the health service having on the society around about it? And I was giving the example of letting contracts. Do we always let food contracts to multinationals that bring in frozen food, or could we not be working with local farmers? So that's not been much on the agenda in England yet, but it is coming on. So that's the new agenda is value. Now, how do we get there? Well, we carry on with the four great things: prevention, evidence-based decision-making, quality improvement, and cost reduction. Have to carry on with those. But there are 5 new activities. Firstly, we must make sure that every individual gets help to make a personalized decision. For example, I would not pay for any elective operation in which the individual had not been given the chance of having a patient decision aid to be absolutely clear, is this right for me? Secondly, we put a new dimension into healthcare. So you need lender and hospitals, you need primary, secondary, tertiary, those are the 2 dimensions. But we need to become obsessed with populations defined by need. People with type 2 diabetes, people in the last year of life, people with back pain, service line accounting like a supermarket. Every supermarket you can see meat, fish, vegetables. And as you walk down the aisle, we call them aisles in English, you see beef, pork, lamb. The health care is the same. So we focus on populations and divide the budgets that way. The third thing is to define a single system specification for Austria. We could do it for Europe. What are we trying to achieve for people with rheumatoid arthritis? The outcomes are the same in Manchester or Vienna or Manitoba or Melbourne, but we'll never get it in that way. But we should certainly have a single system specification. What are our objectives, our strategic objectives? Fourthly, we deliver through networks, not through hospitals and health centres, but through networks. This is the century of the network. And the fifth, perhaps the first, certainly the most important, how do we create a new culture? And we had a discussion this morning about the concept of stewardship. We're the stewards of the planet. We don't own it, but if we mess it up, it'll be our grandchildren that suffer. So we are the stewards of the health service. Collective responsibility would be another example of that. By that, I mean every frontline clinician feeling, not making decisions on the basis of money for the patient sitting in front of them, but having a feeling that we need to be responsible for the value of what we do. So, very interesting morning, and I see change taking place here, and the change is inevitable. Need and demand will increase faster than resources. Structural reorganization will not do anything. We need culture change and new systems. And I look forward to working with colleagues in Austria on this.